Welcome to Mental Disabilities and the Criminal Justice System. I'm Elizabeth Kelley. I'm a criminal defense lawyer, and I specialize in representing people with mental disabilities. On mental disabilities and the criminal justice system, we provide information and hope to people with mental disabilities ensnared in the criminal justice system, as well as to their families. In this episode, we are joined by Dr. Hal Wortzel. Dr. Wortzel has many credentials, including but not limited to, he is board certified in psychiatry, forensic psychiatry, and behavioral neurology and neuropsychiatry. And he is also the co-director of the VA Suicide Risk Management Program, which is headquartered in Denver, Colorado, but which in fact is a national program. Thank you, Dr. Wortzel, for being with us today.
Thanks for having me. Happy to be here.
I first encountered you because of your expertise in FTD, that is frontotemporal dementia. But I have subsequently learned that you also have particular expertise in PTSD, post-traumatic stress disorder, as well as TBI, traumatic brain injury. And as I said in the intro, you are affiliated with the VA Center in Denver. Let's talk about those three different issues, and in particular, let's talk about how people with those various conditions can sometimes, not always, but sometimes become justice involved. First of all, what is FTD?
So FTD stands for Frontotemporal Dementia. So there are a number of neurodegenerative illnesses that can overlap, but they tend to start in their early stages to affect particular brain areas. So for example, Alzheimer's disease, starting with some what are called medial temporal lobe structures important for new memory encoding. So forgetfulness being a well-known and common early manifestation of that illness. Frontotemporal dementia, as the name implies, initially targets frontal and structures of the brain, including the frontal lobes, and parts of the brain that are particularly important for behavioral control, right? People being able to abide by rules and comport themselves according to societal rules and expectations.
Now, you said earlier that people with FTD people earlier in life can be susceptible to FTD. How is a doctor like you able to understand that it is in fact FTD and not some other condition?
Sure, that's a good question. So, by earlier in life, FTD it's still it's a dementing illness. It affects adults. It just can start earlier than a lot of other neurodegenerative diseases, right? So some folks with FTD might start to get pretty ill in their 40s, 40s and 50s, whereas Alzheimer's disease tends to be a bit later. And your question is an important one because FTD is not historically received a lot of attention. A lot of clinicians still are not terribly familiar with it. And because it early on can affect behaviors, it's frequently mistaken with various psychiatric conditions like bipolar disorder, for example. And so it can be a little bit difficult to initially recognize, particularly for folks who don't have expertise in that area. But some of the clues are that, that later onset in life, oftentimes without a mental health history, such that the behaviors that start to emerge really don't have the context that one would anticipate oftentimes, right? So it constitutes a remarkable change in character sometimes, often associated with apathy or disengagement from things that a person previously deeply cared about or was passionate about, like family and careers and things along those lines, being some of the more salient features.
And my layman's thought is that to the degree that FTD is mistaken for bipolar disorder, it might be treated the same way as bipolar disorder, and that could be destructive, correct?
Well, it can potentially be problematic. As with anything that injures the brain, neurodegenerative conditions like FTD can make people more susceptible to side effects from medications, for example. And if, for example, a psychiatrist mistakes FTD for bipolar disorder and starts treatment with something like lithium, that individual might be more prone to having significant side effects from that treatment, or getting delirious from the medication. So, as well as it is the kind of disease that has very grim implications, but implications that people, really need support for and need to start planning for to optimize what is inevitably a very difficult situation.
And because of the problems with the frontal temporal lobe, I am assuming that people with FTD may sometimes become involved with the criminal justice system, correct?
Yes, very much. Dr. Mendez is a neuropsychiatrist, behavioral neurologist who's written considerably on that subject. And in fact, I often reference my own move into neuropsychiatry and behavioral neurology with that condition. In that, I believe back when I was a forensic fellow working in a prison setting, when FTD really wasn't well known or talked about, encountered an older adult who had acquired a diagnosis of bipolar disorder in the context of behaviors that emerged late in life, and at that time it didn't make sense to me that it was bipolar, but I think lacked the skills or background in these areas to recognize what, in retrospect, I believe was FTD.
And what types of offenses are people with FTD most often charged with?
Oh, that can really run a gamut. Some individuals, they get into driving offenses, problems behind the wheel. Oftentimes, as their inhibitions break down and they gravitate towards peculiar interests, those can be unfortunate interests that might involve things like pornography and viewing it in inappropriate places, or judgment that breaks down such that they're leaving the home in unclothed or exposed states. And so it really can result in some really unfortunate circumstances where you have not only criminal charges, but criminal charges potentially of a sexual nature, potentially involving children, and triggering all sorts of sentencing enhancers. And so it can really develop into some very unfortunate and serious legal ramifications.
And I appreciate the fact that you're not an attorney, Dr. Wortzel, but I would imagine that given all that, an attorney could present to the court that there are potentially competency issues, sanity issues, or even if the case does proceed and the person is put on probation, they wouldn't necessarily learn from a probationary sentence. Are those assumptions correct?
Yes, with the caveat that, right, it all depends, and it depends on where you are in the course of illness. So going back to FTD is oftentimes mistaken for primary psychiatric disorders or even things like, sociopathy. Part of that, and part of what makes it challenging, is unlike Alzheimer's disease, where early in the course of illness, people's memory and cognition is breaking down, sometimes in fairly obvious fashion. What we typically describe as, memory can remain intact early in the course of FTD, with the earliest manifestations being those behavioral issues, right? So the untrained eye, this person is cognitively intact, even though they probably have what are called executive deficits. And you mentioned competency, right? So if you ask that person, what's a judge, what's a jury, what are your charges, they can articulate, the knowledge and might even know that what they did is illegal and wrong, but lack the capacity to comport their behaviors to the requirement of the law, which, as you know, in many jurisdictions, under things like McNaughton rules, it's really knowledge of wrongfulness. And so they superficially tend to pass those tests because of the odd combinations of behaviors with intact cognition, relatively intact cognition early in the course of illness.
Yeah, and superficial is a key word in that context. If you've just tuned in, we're talking with Dr. Hal Wortzel, who is co-director of the VA Suicide Risk Management Program based in Denver, Colorado, which serves the entire country. Let's switch gears a bit, Dr. Wortzel, and talk about two issues which are, I don't want to say unique to the veteran population, but when people think of them, people tend to think of veterans. That is to say, PTSD and TBI. First of all, what is PTSD? And how do veterans with PTSD tend to become caught up in the criminal justice system?
Sure. So we're of course switching gears here, right? And so unlike FTD, which is an illness that we don't understand the precise causes, it comes on later in life, as opposed to PTSD and TBI, we can kind of describe as acquired injuries. PTSD, post-traumatic stress disorder, being essentially an emotional injury, traumatic brain injury being a biomechanical injury, but they both affect the brain, right? And in many ways, affect the brain in ways that overlap considerably. So post-traumatic stress disorder involves exposure to events in life which are traumatic. That typically involves significant emotional stressors, things that involve genuine fear for life or limb, but it can also involve sexual assaults or abuses or things of that nature. And it results in a variety of symptoms. Some of those symptoms involve re-experiencing of the event, right? So nightmares that thematically touch upon the traumatic event, or flashbacks, very intensive experiences where it's almost like reliving the event as it had occurred, with the sights and the sounds and the smells. Or it can just involve, I shouldn't say just, because they can be very distressing, but intense intrusive memories, right? That memory breaking into your consciousness frequently and in inopportune ways. And those are the symptoms that I think most people are sort of familiar with, but a lot of the sometimes the most devastating symptoms of PTSD come from other domains. So, for example, avoidance symptoms. So individuals can go to extraordinary lengths to avoid anything that triggers their memories or distress associated with that emotional trauma, which can result in withdrawing from various life circumstances, including things like family and friend. And then there's the hypervigilance symptoms, right? If anybody's been around someone with PTSD and had the experience of you close the door too hard or drop a pot and they jump out of their chair, that hyper startle response, watching your back all the time, that almost can start to feel a little bit like paranoia in more intense forms.
And tell us a bit more about TBI.
So TBI stands for traumatic brain injury. So that is an injury that involves biomechanical forces acting on the brain, right? So a soldier exposed to a blast, for example, or a civilian who was assaulted and hit in the head. It has to be a substantial, injury. And it comes in a tremendous range of severity, right? So on the most mild end of the TBI spectrum, you have someone who maybe sustains a blow to the head and is momentarily dazed, stunned, or confused, but never loses consciousness, as opposed to in more severe forms, right? There are individuals who sustain devastating traumatic brain injuries and are unconscious for days, weeks, or months, or even longer. And not surprisingly, of course, the implications of that injury can range as well. But the front end severity of the injury event oftentimes, helps us to some degree predict what the outcome is going to look like.
As I mentioned earlier, a small number of veterans who have PTSD or suffer a traumatic brain injury become involved with the criminal justice system. What resources does the VA provide to those individuals, their families, as well as often their criminal defense lawyers?
Yeah, so the VA has programs that try to offer some assistance sort of on both ends of the justice system. So the Veterans Justice Outreach Program really tries to get involved on the front end, right? So potentially, if you're in a jurisdiction where maybe there's a veterans court and getting involved in treatment, might help avoid incarceration and get someone instead to the treatment that can really, mitigate some of the causes, perhaps, of that problematic behavior. A veterans justice officer or outreach person can, help coordinate or be a liaison between that court and the VA to help get that veteran those sorts of services and report back to the court that those things are happening. On the back end is the reentry services, and that is more sort of for individuals who've already been through the justice system, have served a prison sentence, and now they're coming out and need to sort of reintegrate back into society. And so the VA trying to capture folks on that end of the justice system, helping to smooth their transition, make sure there aren't gaps in healthcare and in particular mental health care to help ensure a stable transition or potentially assistance with associated sort of housing or case management needs in that context.
And if any family members want to learn more about the resources of the Veterans Justice Outreach Program, where should they go? What should they do?
Sure. So the VA's website has information and links for that. It's actually housed under the VA's, both of those programs are housed under the homeless program. Of course, not all those individuals are homeless, but that just happens to be, where it is housed. And if you Google VA Veterans Justice Outreach or VA Reentry Programs, the VA website should pop right up for you, or it's va.gov/homeless/reentry.asp for the reentry program.
Speaking of which, I announced a couple of times your title as co-director of the VA Suicide Risk Management Program. What are some of the resources that your program offers?
So we've been around for a little over a decade now. The idea being that the VA's worked hard to create more uniform risk assessment and risk management procedures, for all veterans in our system of care. But we want that also to be available to veterans who elect to receive their care elsewhere, perhaps in the community. And a lot of the things that the VA has done to advance or sort of push the needle forward in terms of suicide risk assessment and management have started to spread into the community. Things like safety planning being a good example. And so as we've tried to partner with our community partners, to make sure that they too are sort of abiding by standards of care or best practices, we can offer consultation to anybody working with veterans inside or outside the VA when there's concern about suicide risk. And so that can involve questions about risk assessment, risk management, sort of programmatic questions. And so that is a resource that's widely available. And then, of course, depending on the consultation question, we oftentimes are following up with various sorts of resources or educational programming that can help, advance some of those lessons.
One of the stigmas, if you will, about the stigma that is out there is that veterans, because of their training, because of their courage and their strength, do not want to admit vulnerabilities. How do we as a society encourage them to reach out for help?
Yeah, I mean, there is still a lot of stigma out there, right? For a lot of individuals, it's still very. I mean, and I think we've made progress in this regard, but understandably, it can still be hard to ask for help. It can still be hard to acknowledge, that you're struggling, particularly, right? If you're, a young man or a young woman, or who very much identifies with that identity of a soldier or Marine or airman or sailor. Right? And so, right, that clear and consistent messaging that asking for help does not. Strong people also ask for help, and that's okay, and it can actually be a form or sometimes the strongest thing to do is ask that help so that we can be in turn stronger for the people around us, the people we care about, better attend to our responsibilities. So it can be a tricky message to deliver, but one that we hopefully are all doing right. Suicide prevention, as the saying goes, is really sort of everybody's business these days, right? It's such a big societal issue. It can't be just right medical providers. We're trying to really get everybody supporting these individuals, and the reasonableness, the strength that comes from asking for help.
I want to wrap up this episode on a note of hope, and I want to discuss each of these three major issues, that is to say FTD, TBI, and PTSD. Let's start with FTD. If you are a family with a loved one who has FTD, how do you prevent that person becoming involved in the criminal justice system? And if unfortunately they do become involved, what should you do?
That's a really tough question. FTD is a very tricky illness for everybody to manage. Caregivers, and we don't have great treatments, and we certainly don't have cures for it, right? So we do try to, to the extent that we can, try to contain these behaviors and keep everybody safe. And oftentimes the things that we can exercise control over is not the illness itself, but the environment around it, right? So trying to, and that's why I said before, getting help early to help establish boundaries and problem solve around these sorts of issues in terms of, right, what can we do to make a home safer so that, we worry less about folks wandering off or getting into a vehicle or into the kinds of situations where they might get into trouble, really trying to be proactive about problem solving and containing on the front end. And then if and when folks do get in trouble, with the law, I mean, being again proactive about making sure, right? A lot of attorneys have never heard of FTD either, and making sure that they know what this is. There are a lot of communities have great support programs. They should, certainly, look into that. Benefiting from other folks who've been through this. And their experiences and what's worked and not worked for them can also be tremendously useful.
And I imagine that some of the same strategies apply to TBI and PTSD. So in other words, what preventive measures can families take for a loved one suffering from TBI or PTSD? And if that loved one does become justice involved, what should the family do?
Yeah, and so those conditions are quite a bit different because we do have lots of evidence-based therapies that are potentially useful there, right? So in particular for post-traumatic stress disorder, if someone's struggling with that, and in part that's leading to some of the behaviors that's leading to legal problems, right? We have some really good evidence-based psychotherapies for PTSD. Medications can also be part of that treatment equation. And so folks can get a lot better and learn to, right, the memories never go away, but we can learn to manage them in much more effective ways, moving forward. And sort of analogously with TBI, again, it depends on the severity, right? Some folks have devastating brain injuries where the management can involve some of the containment type strategies that are analogous to FTD. But for a lot of individuals, right, we can still help them learn skills or afford treatments that help mitigate some of the impairments or help them capitalize on intact abilities to sort of work around areas of impairment. So, right, every case is a little bit different, and it requires a very sort of patient-centered approach. But those two conditions, I just want to emphasize, right? There are treatments that can be very helpful in those settings.
All right. Well, Dr. Hal Wortzel, thank you so much for joining us. Thank you for sharing with us your experience, and we will put up on our show notes some of the many resources you described.
Thanks again for having me.